biyolojik psikiyatri ile ilgili iki sunum.
After two presentations about biological psychiatry, I'm going to talk about something more clinical and social, factors affecting the continuity of attention deficit hyperactivity disorder treatment, and what kind of components are important in this treatment. In every 4 years, we give a seminar where we share our experiences on this matter, and it's now going to be a similar type of presentation. Can I get my next slide, please?
Teşekkür ederim.
As you know, attention deficit hyperactivity disorder is a common problem among children. 5 to 7% of school-age children are affected by this. And some of the studies show that this is a long-lasting disease. I prefer it to be long-lasting. It is a treatable childhood psychiatric disorder. Pharmacotherapy is the first-line therapy for attention deficit hyperactivity disorder when it comes to children and adolescents. Stimulants and non-stimulant drugs are effective in the treatment of ADHD. However, those drugs can improve only symptoms when patients continue with those prescribed regimens. And when the medication is discontinued, the treatment benefit also disappears. Treatment is required as long as the symptoms persist in attention deficit hyperactivity disorder. As long as the symptoms meet the diagnostic criteria, the treatment should continue. Despite such clear findings, and despite the documented benefits of medication, many parents are hesitant to start medication. Discontinuation of the treatment right after initiating the drug is what we see most commonly, and adverse effects and concerns about stigmatization are usually associated with the discontinuation of the drug, even when the medication shows its efficacy. Therefore, understanding the reasons for discontinuation are very important, because this is something that contributes to the improvement of healthcare in this disorder.
Ve zayıf tedavi devamı.
Poor continuity results in suboptimal symptom management, precursors for negative long-term outcomes, problems in tolerability of the medication, stigmatization problems, and higher economic burden. And we also see that sometimes children are being labeled unnecessarily because of an unnecessary treatment, so it means a loss of time and energy. For psychopharmacological agents and for compliance to that agent, different factors have to be taken into account, like the patient, the medication, and environment, gender, age, socioeconomic status, severity of symptoms, functioning, comorbidity, personal attitudes, perceived benefits are important factors for the increasing of compliance and continuity when it comes to the patient component, and the type of treatment, clinical response, complexity of drug regimen, and scheduling of appointments are also important from a medication perspective for the same purpose. From an environmental perspective, the patient-doctor relationship, doctor characteristics and attitudes towards the patient, family support to the treatment, family dysfunction, society thoughts, and the role of social media are important. These are also other factors which have an effect on medication adherence and continuity. In all chronic diseases, compliance and continuity are important, so this is a problematic for us all. WHO 2003 data showed that in chronic psychological problems, adherence and continuity are only 50%, and in all adolescent and pediatric patients, compliance to antidepressants is 40 to 60%. When we look into the literature, we see that the mean adherence rates for ADHD medications is between 12 to 84%. The interval is this large because the sociocultural factors are different between different groups of people, and the implementation method of those trials, like being retrospective or prospective, have a different effect on the outcomes. And in ADHD, continuity studies show that 1 year continuity rate is between 53 to 81%. 3-year continuity rate is between 21 to 70%, but the retrospective and population-based studies show that 1 year continuity has a lower rates, like between 12 to 43%. The factors associated with the continuity of the medication are factors like a younger age, having no comorbidities, better family function, greater symptom severity, concurrent psychotropic medication use, especially this variable is a variable which depends on the healthcare registration, and long-term methylphenidate use of the extended release type is also found to be an effect which has an influence on the same thing. The factors which lower ADHD medication adherence and continuity are dosing frequently more than once per day, male gender, older age, stigmatization or confidentiality issues, because the families may have reservations about those, side effects of those drugs and lack of medication effectiveness, short-acting stimulant and non-stimulants might be another important factor, and at the same time, in adopted children and in children taken care of by the institutions, compliance is much better, but when you're living with the family or your parents, the compliance is not that good. In Sakarya, a 4-year trial has been conducted by our team, so we wanted to see our own continuity and adherence rates. We had approximately 1,500 children being followed up with the diagnosis of ADHD. But we've included only the patients who were meeting the criteria. Actually 1,100 of them were in line with our study criteria, and we reached 877 of those children and adolescents and asked them questions on the phone. The ages are between 6 and 18, and then we referred to those are usually children referred to child psychiatry outpatient clinics of Sakarya University. Socio-demographic data were used in our trial, and also the symptom severity was evaluated by Turgay ADHD scale, and for the effectiveness evaluation, the clinical global indices was used. 6-month treatment continuity was found to be 43.4%. 1 year continuity was found to be 30%. It actually meant using the drug for at least 9 months because we gave a drug holiday during summer. This rate was 30.2%. Compliance with the treatment during assessment was 30.7%. The treatment gap longer than 3 months was applied to 14.6% of the patients. When we reached the patients by phone, we asked 608 patients why they discontinued the treatment, and the most important answer they gave to us was that they weren't able to get an appointment from the doctor, and you may think that there are no problems with the family, but it is really difficult to get an appointment. 17.9% of the families said that there was an improvement in problems. This wasn't something we were expecting because in the files there was this decision about the continuation of the treatment for the patient. So we said we either made the wrong diagnosis or there were some problems about the expectations of the family, and unwillingness of parents and stigmatization for drug treatment was seen in 11.2% of the patients. The ineffective drug treatment was again 11.2%. Familial problems made up 8.9%. Medication refusal by children was 7.7%. Displeasure about health services was 3.9%. And objecting to this drug treatment was also another problem. Objecting the treatment and medication refusal by children were parallel with one another. 4% of those were not happy with the services they got, and 8% of those people discontinued the drug because of other reasons. In our trial, similar to other trials, younger age was a positive variant for the compliance to the treatment. High education level of the mother was related to the continuation of the treatment, whereas we did not find such a relationship between the education level of the mother, between the level of the father and the compliance. Higher hyperactivity, impulsivity, symptom severity was also very important. And the medication type was also playing a very important role. In 1 year continuity, we saw that metrophenidate use was 5%, Ritalin 5%, Concerta 10%, and we had Concerta use on a 10% basis. In 1 year continuity, metrophenidate, Ritalin, and Concerta use were better than Stretta, but in 6 month continuity, Concerta, Ritalin, Concerta when compared to Ritalin was found to be much better. Comorbid medication use is also another problem in terms of the continuity of the treatment. Of course, absence of side effects was also another important factor. Adding another drug for psychiatric problems is what we see very often, so the data may not be very reliable for this purpose. The higher initial effectiveness of the drugs were chosen, which means the first lack of side effects were observed, but clinical global indices points were found to be higher in terms of 1 year continuity with the medication. In our trial, gender, education level of the fathers, age of parents, marital status of parents, family history of psychotropic medication use, developmental delay, chronic health conditions, inattention and behavior problem severity, and presence of psychiatric comorbidities were not found to be related with 1 year continuity of medication, whereas the previous ones I talked about were found to be related with the continuity of the drug use. Attention and behavior problems and medication continuity were also not found to be related with one another. Attention severity or attention symptom severity and continuity are found to be related to one another in other trials, but we did not see the same thing. Behavioral problems presence in children we worked on increased the motivation of the parents, but in terms of children and youngsters, it was a risk for the discontinuation of the drug, and the presence of a comorbidity was also important. Comorbidity was 45% in our trial, and the comorbidity presence was not affecting the continuity of the treatment. What can be done about the continuity of the medication? I think the first thing which we have to do is to improve the healthcare system. And in our trial, 20% is the rate of those who could not continue with the medication due to the lack of ability to get an appointment. This usually means a waste of energy by the doctor and an unnecessary spending. And in terms of families, it means unnecessary stigmatization. And we all work in government hospitals and research and training hospitals, so we know that these sessions are very short. We see many patients, 1,500 children's files have to be seen by 2 doctors only per year, and more frequent follow-up is going to have a better continuation in our experience. Children, parents, teachers, society being more educated on the disease and the treatment is going to be helpful. Better communication with the teachers and getting their support will definitely have a positive effect on continuation of adherence. And media and informing the community by the media is also going to have a positive effect on